Hi, this is Dr. Fazeli. I'm a geriatrician in Southern Maine. I'm recording this video for the Maine Medical Directors Association for the benefit of my colleagues in nursing homes and assisted livings. In this video, I would like to review the recent long-term care survey done by the Maine Medical Directors Association around COVID-19 testing. And I would also like to review a COVID positive case that we had today at Durgan Pines Nursing Home. The purpose of the survey was to evaluate the impact of the restrictive testing guidelines in nursing home facilities and also to assess the availability of testing swabs at the facilities. This is an op-ed that I wrote in the Bangor Daily News, and this was primarily written to share the information in the survey due to the fact that we were not able to present the data during the CDC medical directors call that was being held every Tuesday for the past 3 to 4 weeks. The testing guidelines that we were concerned about are these. So the first guideline is the AMDA guideline. The different versions of this guideline are available, but they're all an update of this particular algorithm. It shows the common and less common signs and symptoms. And for testing, you would need 2 common symptoms to qualify. This is the Maine Health COVID-19 testing algorithm. This was provided to us by Nordex Laboratory, our commercial lab, to guide our testing. I should note that while this is a Maine Health algorithm, the Maine Health Geriatric Group in Portland has indicated that they are, in fact, using the AMDA guideline. As you can see in this algorithm, asymptomatic exposure cases are not an indication for testing. And in fact, even symptomatic healthcare workers are not an indication for testing. And the rationale here is that they would be quarantined for 14 days. We will look at the impact of this when you do have a case in your home and how that impacts your exposure testing. So let's go over the survey. This indicates where the survey respondents were by county. The number of COVID tests done on residents. So you can see in the first column the facilities who had 0 testing of their residents since the pandemic started. And on the right-hand side of the slide is the number of facilities who had high number of testing. This is the same graph, but it's looking at the testing within the staff of those facilities. So again, about 12 facilities here had 0 testing, and many of them had just a few testing. The analysis of this data shows that 50% of all responding facilities did 0 to 3 tests overall since the pandemic started. Only 32% of these facilities did 9 or more tests on residents in the past 2 to 3 months, and only 19.5% of them did the same number of tests on staff. An astonishing 21.4% had 0 tests done in their facilities, whether it's staff or residents. The question we wanted to ask here was whether or not the facilities are using a restrictive guideline or a less restrictive guideline. So in this case, it turned out that the majority of facilities, about 70% of them, were using the liberal guidelines for testing, including cold and flu-like symptoms and GI symptoms. This, of course, raises the question of what else is causing the low rate of testing if facilities are, by and large, following a liberal testing criteria. And this may become apparent when you look at the swab data in later slides. Slide shows you that more than 50% of facilities know of positive cases in other facilities within 20 miles. This slide shows that some facilities are testing new admissions post-admission for surveillance testing, but the vast majority do not. This is the media coverage of the survey data in the Bangor Daily News. And again, we made it available to our colleagues through the media due to lack of opportunity to present it in full during the CDC long-term care calls. This slide illustrates the number of swabs in facilities, and as you can see on the left-hand side, there's quite a number of facilities that have 0 swabs in their facility. This article by the Portland Herald focused on the shortage of swabs that we found during the survey. The overall swabs in facilities, 26% of facilities had no swabs and 54% had 7 or less swabs. Seeing the result of the survey, I contacted Puritan Medical Group that I became aware of due to local articles about this Maine-based company and their work around swab production and testing supplies. And so I contacted them and asked if they could help. They initially responded by directing me to the Maine CDC and the normal suppliers. And once they became aware that the Maine CDC cannot assist except in outbreak situations, and the normal suppliers have a backlog, and most facilities, our survey had demonstrated that they were low on swabs. They offered to help, and we calculated 50 swabs per long-term care facility with perhaps a few assisted living facilities as well. And we ended up with a number of 5,000 swabs. We got those swabs, and we're currently, with the help of the Maine Healthcare Association in Maine, we are getting them to the facilities at cost. And the cost to the facilities is about $1 a swab. Now I'd like to go over a COVID positive case that we had at Durgan Pines as a case example. This particular case was diagnosed today with COVID. This case involved a patient who was tested in April before admission to the facility. She also had a 5-day post-admission surveillance test that was also negative. She developed a low-grade fever. Yesterday was tested and the test came back positive today. As part of our containment plan for this positive case, we tested 12 residents out of 68 in the building. Those 12 were all in one unit. We also tested all the staff on that particular unit, which comprised 50 staff out of 148 staff in the building. Initially, our Nordex lab, which is our facility lab, declined to run the test for exposure cases due to the fact that they use that algorithm that I showed you before, and they don't allow for testing for exposure cases. They referred us to the state lab, which is run by the CDC, and we were surprised to hear that they would not run our swabs that we had just collected because we are yet to have 3 positive cases. After multiple attempts to rectify this issue with the state lab, we turned to Nordex again, and we told them that the state lab is not running these labs and we need to test our exposure cases. Fortunately, Nordex made an exception and tested all our samples. And as of this hour, as I'm recording, all the residents were negative, and we still have 12 of the staff tests pending, but the rest were negative. While we are very happy that Nordex did run those tests for us, and we're even happier that the majority of these tests are coming negative so far. We were obviously not happy that our own state lab had denied testing, and we were surprised to find out that the Maine CDC actually not only denied testing, but denied ever saying that they wouldn't run these tests when they were approached by the media. Of course, we do have emails to that effect, and we had multiple individuals calling the CDC. What's also surprising is that the Maine CDC declined to share a copy of the protocol they cited when they declined the test, and they're telling us that this protocol and algorithm is a confidential department document. So, what is the future of testing in nursing homes based on the experience of other states? If you look at the states or New Hampshire, they went from minimal testing like everywhere else to mandatory weekly testing. That unfortunately has not changed some of the outbreaks that they've been having, but it is very tempting for decision makers here in Maine to follow in their footsteps because mass testing and universal testing implies more and implies maximum testing. However, there are shortcomings that are apparent to us geriatricians, and one of them is the fact that if you have scheduled tests, that may distract from testing for new symptoms that might emerge between tests. So imagine, for instance, if you had mandatory testing done on Mondays, and you have a resident or staff member that develops symptoms, mild as they may be, on Tuesday, Wednesday, and we have to ask the question, would we be tempted to not test those people just because we had a negative test 2 days prior and we expect them to have weekly tests on an ongoing basis? That might be part of the reason that there are still outbreaks in states where there is universal testing, in buildings where they're actually testing on a weekly basis. The reliance on universal testing as a cure-all for the pandemic in nursing homes is misguided and needs to be reconsidered. So the universal testing can be a good snapshot in time, which gives you a good baseline, but it is not a substitute for ongoing targeted smart testing. The other issue is the false results resulting from frequent testing. The Maine CDC recently expressed concern that with universal testing, there may be a risk of more false positives. I would argue that in dementia patients receiving weekly swabs are more likely to have false negative tests due to the fact that they're likely going to resist and will result in suboptimal specimen collection. Now, the same cannot be said for staff, although I also consider the factor of complacency on part of the staff if they feel that they're being tested every week, that that's the solution and that's the holy grail, and they may lose focus on everything else they have to do to mitigate the infection among themselves and their residents. So, what is the ideal testing that we can hope for nursing homes and assisted livings instead of universal testing? One is testing of mildly symptomatic residents and staff that comprise the vast majority of COVID cases. The other is screening of all admissions from hospitals to nursing homes and having a mechanism for surveillance screening post-admission. The other is the screening of asymptomatic exposure cases, like we did today in our case at Durgan Pines. We screened residents and staff for exposure. Staff working with COVID patients, obviously, they need surveillance testing on a weekly basis at a minimum. and staff working in multiple facilities, which in case of Maine, they comprise about 46% of our workforce. Please see our testing guideline at the Maine Medical Directors Association website, the mainemda.com, and feel free to copy, print, and use that guideline without the need to request permission. Feel free to send me any questions via email, and please stay safe, and thank you for your service.